When assessing for suicide, the first thing we need to understand is what is suicidal ideation. Suicidal ideation, on the surface, is where an individual is thinking about suicide to a varying degree. This varying degree is where understanding suicidal ideation gets a bit more nuanced. Ideation can range from a person simply acknowledging the possibility and their own ability to kill themselves, to considering specific methods, to formulating a detailed plan of how, when, and where. And the importance of a suicide risk assessment is to understand the severity and details surrounding an individual's suicidal ideation. But to do this, we have to ask one question first. Are you having thoughts of suicide? If someone says yes to having thoughts of suicide, that's where we can go into the details of what's going on. So the next question to ask is there a plan? And this involves, again, specific methods, specific locations of where they plan on suiciding. When do they plan on suiciding? And again, it's important to understand each individual component of this. So when we're asking about a plan, we want to ask, do you have a specific method in mind? This could be pills, cutting themselves, firearms, hanging themselves, or maybe trying to make it look like an accident while with a car accident. Do they have a specific location where they plan on doing this? Is there a garage that they want to jump off of? Is there a specific time that they plan on doing this? Are they waiting for insurance to go through? Or are they waiting for a significant date to pass? Maybe they want to just get through mom's birthday first, and then they plan on suiciding. Once we ask these questions about the specific method and plan that they have, then we want to start asking about intent. So scaling questions can help here, and these sound and look like a little bit sort of, if you're with an individual who's having suicidal ideation, you ask, okay, on a scale of 1 to 10, what's your intention of wanting to act on your thoughts of suicide? And sometimes it's important to give an individual a defined range. What do these numbers mean? When I'm working with someone who's having suicidal ideation, I like to say, okay, on a scale of 1 to 10, how likely are you to act on these thoughts of suicide, or how strong is your intent to act on these thoughts of suicide? With 1 being these thoughts are just a passive itch in the back of your mind, to 10, you've already attempted, you've already completed, and you're dead now. With giving that very defining range kind of helps the individual better define their intention of where they're at. Otherwise, because they're in emotional crisis and everything's firing rapidly, if you just say on a scale of 1 to 10, how strong do you want to do this, you may be getting numbers like 44, 60, 1,000, a million, and it kind of helps us to have a better understanding and an accurate gauge. And so giving these defined limits helps us gauge better an individual's intention to act on their thoughts of suicide. So one thing we want to talk about too is some risk factors that can increase an individual's risk for making an attempt. One of the most important risk factors to explore are prior suicide attempts, and this is again where it gets a lot more nuanced. Prior suicide attempt is not where in the past they've attempted to hang themselves and they've survived, or they've attempted to overdose and they've survived. This is only one style of a prior suicide attempt. Another style of suicide attempt that's important to explore are aborted suicide attempts. This is where an individual may have gotten everything ready. They may have gotten the noose ready and they stand on the stool and maybe they even put their heads through, but at the last second, they take the noose off, they step down, they reconsider and maybe just go to sleep or reach out to someone or talk it through. Or it could be they get the gun ready and they load the pistol, but then they decide to lock it up. These are aborted suicide attempts are when an individual has taken steps to plan to end their life, purposeful steps to where they plan to end their lives, and then they aborted the plan and put it on hold or completely disassembled it. Another style of suicide attempt that we must explore are interrupted attempts. Interrupted attempts are where they may have overdosed and a family member walks in, or maybe they have the car running in the garage and someone walks in. This is where some sort of third party notices them standing on the bridge or something and pulls them back, interrupts the attempt, and brings in emergency services, contacts the counselor, and further steps are taken to try to keep that individual safe. And one important thing to note is when we're exploring these aborted, interrupted, and survived attempts, these can give us clues and understanding of other factors going on in their lives that can help us when we get into safety planning. When they aborted, why did they abort? Did they think of someone important that they did not want to hurt with their death? Or if it was interrupted, is there a spouse or a best friend who is actually constantly there for them that we can rely upon to be a social support in the future? This is why it's important to explore these things thoroughly. It is important to also to be able to differentiate between non-suicidal self-injury and a suicide attempt. And it can be done by referencing a recent act. So if someone is presenting with suicidal ideation and they have cuts on their arms, or they may have done some other injurious act, it's important to ask if when they did that self-injurious act, cutting, substance abuse, banging their head against the wall, etc., asking if when they did that act, if any part of the individual wished to die as a result of the self-injurious act. Again, it's very important to ask that any part of, because sometimes someone could be cutting 99% to relieve that emotional pain, but 1% may have been hoping that they would die. If that 1% is there, then that's a survived suicide attempt. If they 100% did the self-injurious act with the purpose of emotional relief or some sort of physical distraction, etc., then that is not considered a suicide attempt. That's just non-suicidal self-harm. It is important to inquire about both past and current substance use and abuse. If an individual is currently under the influence, they are much more susceptible to impulse and may be unable to adequately safety plan. Many times, substance use can also be a part of an individual's plan or the plan itself. It is important to inquire what substances and how much an individual has taken and pass this information on to the next appropriate care provider. Also, a current substance use disorder or addiction can be a foundation for an individual's suicidal ideation, as they may be experiencing intense feelings of shame and helplessness when they're battling the substance abuse addiction. The next risk factor to discuss with someone is their exposure to suicide. If they know someone that has died by suicide, whether it be a close family member, a distant family member, a friend, or acquaintance, this comes with an increased risk to the currently suicidal individual. Losing someone to suicide comes with complicated grief, because losing to someone to suicide is much different than losing someone to a sickness, disease, or just old age. It comes with senses of guilt, of they feel that they could have been the one to stop whoever died by suicide. They may blame themselves for not having done enough or not having been at the right place at the right time. Losing someone to suicide also comes with a stigma. There is still a stigma about people who die by suicide, that they're selfish or that they were insane or crazy or all these other things. And it makes it hard for the grieving individual to discuss these things. And so it leads to isolation. Grief is an already painful and complicated process, and then to be further isolated because it's hard to discuss this stigmatized topic complicates the grief even more and compounds on the risk factors for suicide that the individual is already experiencing. The next thing we want to discuss with an individual are precipitants or triggering events. This is the why of their suicidal ideation. With suicidal ideation, there's an underlying foundation of pain, whether from multitude of concerns such as depression, bipolar, anxiety, PTSD, substance abuse disorder, or chronic physical illness. There can be financial struggles. Sometimes it's just a singular, impactful, and traumatic event, the loss of a loved one, rape, violence, a breakup, or a fight with family or friends, an instance of abuse, or the loss of a job. Each individual has unique struggles and adversities that underpin their suicidal ideation, and it is important to at least know and be aware of the main triggers of their ideation. To understand these things, we can simply ask, what's going on? What's happened? If there are a multitude of concerns that are overwhelming for the client or you, the provider who's asking, sometimes asking about just the most recent or the most impactful thing that has happened can help guide the conversation towards an effective path of understanding their ideation and eventually leading towards a discussion of safety planning and intervention. After discussing risk factors, it is important to go over protective factors. This is the flip side of the coin of suicidal ideation. One of the first protective factors is ambivalence about suicide. As I mentioned earlier when we were discussing risk factors, this is something that can maybe be discerned when discussing previous suicide attempts. If there's ever an aborted suicidal attempt, asking what motivated the individual to abort that suicide attempt can be a very deep and important clue about their ambivalence about suicide. This could be reasons for living, reasons why they don't want to die, and it can range from just sheer being afraid of death, not wanting to hurt families, being afraid of pain, being afraid that they may fail their suicide attempt and be permanently disabled. The next protective factor is social support. As we were discussing earlier about ambivalence around suicide, people such as family members or friends may be a reason why someone may not want to attempt. These social supports can be important to dig deeper into. Is there a family member that the person feels that they can discuss their problems with, they can discuss their precipitating events with? If they're having financial struggles, is there a family member who can help them out in a bind? If they've gone through a breakup, is there a best friend who can help them sort through the emotional tangles of that breakup? Social support can also directly address one of the main underpinnings of suicidal ideation, which are feelings of isolation. If we can help that person reconnect with their social support, then we can directly confront their feelings of isolation. Another important protective factor to discuss is mental health care access. Understanding the access an individual has to professional mental health care is important when safety planning. It can help them do long-term planning to address the long-term issues that may be fueling their suicidal ideation. Inquiring about these mental health care professionals can come up naturally as you're talking with the individual who's in a suicidal crisis. If there is a mental health concern that's discussed when exploring precipitants, it is a logical next step to ask about if they have any mental health supports or if they're taking any psychiatric medication, and asking if they've been taking that medication as prescribed. If someone states, "I've been struggling with depression for X amount of years," it is reasonable to reference this and ask, "Are you seeing anyone for this depression? Do you have a counselor, a therapist? Are you taking any medication for this?" These are important pieces of information to use when you safety plan with them further. Sometimes we can find out about an individual's future plans or goals when discussing their plan for suicide. Their plan for suicide may be contingent on a predicted future failure of a life goal. If we find out this life goal, we can reframe it as a point of hope and opportunity to strive for. A final protective factor to discuss are beliefs about suicide. Typically, these tend to come as religious beliefs. An individual may feel like it is a sin to suicide or they don't want to go to hell, and so this is one of the things stopping them from making an attempt. Finding out about these beliefs are important because they can lead us towards other forms of connectedness. If they firmly believe that they will go to hell if they were to suicide, then we can start asking them about their religious beliefs and their religious faith and anything part of the religion that provides comfort or hope for them. And this can be another turning point into safety planning. Suicide assessment tools typically come in a combination of both formal and informal screeners, and many of them are free for mental health and healthcare professionals. One suicide assessment tool is the Columbia Suicide Severity Rating Scale. This can be accessed for free at cssrs.columbia.edu. This is a 6-part suicide risk assessment scale that asks questions about whether an individual has a wish to die or to go to sleep and not wake up, whether they're actually having thoughts of suicide. It asks about an individual's method for suicide, their intention, and their plan. And finally, it asks about if they've done any preparatory behaviors for suicide or killing themselves. These preparatory behaviors can range from aborted attempts, interrupted attempts, gathering means for their current plan, etc. The CSSRS, again, is free, and there's also free training available at cssrs.columbia.edu. The next assessment is the Suicide Assessment 5-Step Evaluation and Triage. This is provided by the Substance Abuse and Mental Health Services Administration, or SAMHSA. This assessment goes over how to identify risk factors, how to identify protective factors, conducting a suicide inquiry, determining risk level and intervention, and how to accurately document all of these details. A third assessment tool is the Ask Suicide Screening Questions, or the ASQ. This is provided by the National Institute of Mental Health. It goes over 5 questions, starting with, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past few weeks, have you been having thoughts about killing yourself? Have you ever tried to kill yourself? And are you having thoughts of killing yourself now? As you can see, these questions range in severity and can help produce a sense of rapport and ease the individual in if they're worried about how to respond and how to describe their suicidal ideation.